Welcome to American Nonprofits Equity Webinar Series. This is COVID-19, a matter of equity, and today's session is entitled Connecting the Dots. I am Carmen Marshall, Director of Consulting and leading the equity work here at Maryland Nonprofits, and today I'll be your moderator. I will ask that you enter your questions in the Q&A section at the bottom of your screen, and after we hear the panelists' presentations, then we'll begin to answer as many of your questions as we can get to. This session will be recorded, and the recording will be available shortly after today's presentations. Here today, here at Maryland Nonprofits, we are committed to strengthening nonprofits and their networks toward equity and a greater quality of life. We want to thank today's sponsor, Care First, for their support and sponsorship of this webinar series and today's webinar. We also want to thank Maryland Nonprofits Board of Directors and the Maryland Nonprofits team for their support in the production of this webinar. Today, behind the scenes, I have with me Amy Coates-Matson and Anjaniki Jones working in the production area. Thank you guys for your support during this afternoon session. We also want to make sure that you know that Maryland Nonprofits provides an additional set of workshops via webinar around this equity series, also sponsored by Care First. The next one's coming up on May 21st. So please keep an eye on our webinars on our website so that we can include you in the next session. We look forward to you joining us for the next webinars coming up through May and June. Maryland Nonprofits is also available to assist you through the consulting group with your training and professional development needs. Today, I'm really excited to have 4 dynamic professionals with us, experts in their fields, to talk about how COVID-19 is a matter of equity. And to help us connect these dots are Natalie Burke, President and CEO of CommonHealth Action, Kerry Hawk Lessard, Executive Director of Native American Lifelines, Andria Smythe, Assistant Professor of Economics at Howard University, and Fagan Harris, CEO of Baltimore Core. I'm going to give them an opportunity to introduce themselves and tell you a little bit about their work, and then we'll begin with our first presentation. Take it away, Natalie.
Hi, good afternoon. My name is Natalie Burke. I am President and CEO of CommonHealth Action, and our work is about developing people and organizations to produce health through equitable policy, program, and practice. But more importantly, I am the granddaughter of Irma Burke, and I am the daughter of Joan Burke, and they are what drive me to do this work about making sure that all people have opportunities to achieve their best possible health.
Thank you. Kerry?
Hamitakiapi, Kerry Hawk Lessard, Machiapi, Shanina Vasitu na Orchete, Itaha Imachauge, Executive Director, Native American Lifelines, Hemie. Good afternoon. My name is Kerry Hawk Lessard. I am Shawnee and I am Ocheti. I am the descendant of a boarding school survivor. Our people weren't allowed to use our language. I always make sure that I do that. I'm the Executive Director of Native American Lifelines, which is a Title V Urban Indian Health Program funded by the Indian Health Service and designed to fulfill the trust and treaty obligations that the federal government has to Native people. So thank you.
Thank you, Kerry. Andria.
Hi, good afternoon. I am Andria Smythe. I am a member of the faculty at Howard University in the Department of Economics. I study issues around economic inequality and intergenerational mobility, as well as the role of education, specifically higher education, in promoting economic mobility.
Thank you. Fagan?
Good afternoon, everybody. My name is Fagan Harris. I'm the President and CEO of Baltimore Core. We're a Baltimore-based social enterprise that recruits talented leaders from a range of backgrounds into public service and social entrepreneurship here in Baltimore City.
Thank you so much. So we'll ask Natalie to sort of lay the foundation for us. I'll ask the other panelists to close your video, and then we'll hear from Natalie.
Thanks, Carmen. Next slide. So it's interesting during this time of COVID, how challenging it has been to see the inequities that exist all around us. And my hope is that we can't unsee those inequities, but in fact that they are etched into our minds and into our memories. And in that, the discomfort that we feel now, that we sit in that discomfort so that we can create change. Next slide. So today, what I hope to do is to talk to you a little bit about the role of identity in terms of social identity as it relates to the way that we experience this crisis and the world in general. I want to provide you some context for how we got here, give you some framing around health equity and equity, and to talk a little bit about leadership. Next slide. So one of the things that I think I certainly am proud of and I embrace is this idea that I try to orchestrate constructive discomfort. It's the idea that I challenge people, their thinking, their ideas that they may hold on to very strongly in the hopes that in sitting in that discomfort, we can find a way forward, because I do believe that any great change is preceded by discomfort. So let's get uncomfortable. Next slide. So the interesting thing with America is that we have always been a nation that has struggled with identities. So whether it was the hunting of Native American people, the exclusion of Chinese, denying women the right to vote, excluding African Americans from every part of society and policing them, the exclusion of people with disabilities. When we even look at the policing associated with social distancing, and the inequities that we've seen in that, and the experience of coronavirus as it relates to people of color in particular, and many of those working on the front lines, we are a nation that continues to struggle with identity. Next slide. The inequities that we see, it's crystal clear in the experience of this pandemic, have to do with access to testing, treatment and care, certainly, protections or lack thereof in nursing homes, access to information, access certainly to personal protective equipment, face masks, et cetera, access to the Paycheck Protection Program. For companies and for organizations, we found that certainly African-American owned and Latino owned businesses were locked out of the process, certainly in the first round. And then again, the inequities we see with regard to law enforcement of social distancing. All of these things indicate that identity drives the way that we are experiencing this pandemic. Next slide. More than that, identity in this society tends to drive whether or not you have the opportunity to even be healthy. Next slide. So this concept of health is really important, and it's this idea that we want all people to get to their best possible health. So the technical definition, the attainment of the highest level of health for all people, sounds lofty and it sounds amazing, and it's what those of us in public health strive towards. But what we're finding is that we are far from it. Next slide. Instead, what we are witnessing, what we are experiencing throughout our society, from state to state and in communities all around the country, are health inequities. So I know many of you may be familiar with the term health disparity, but I want to make sure that we differentiate. A health disparity is merely a difference in health status or health outcome. And in and of itself, that difference doesn't necessarily have to be a bad thing. When it becomes a bad thing is when that difference in health is the result of systemic, unjust, avoidable decisions that we are making with regard to policies and practices that are creating barriers to people having the opportunity to even be healthy. So our work really has to be, regardless of your sector, regardless of your discipline, regardless of what your organization does, just figure out what your role is in the production of health equity or health inequity. Next slide. So in this experience of COVID-19 and people of color, I think we have peeled back many layers, and it amazes me that some people are actually surprised about the inequities that exist. Next slide. So here's what we know to be true. Oppression is killing the oppressed. So those people with oppressed identities in our society experience the world in a different way. And in that, there is an inherent stress that actually factors into the existence of chronic disease. Next slide. So when we look at what we talk about as the social determinants of health, things like housing, education, transportation, employment, and healthcare, not only do they lead to chronic stress, they lead to chronic disease. And this becomes really important when we start to talk about coronavirus. Next slide. When we look at the way that coronavirus is being experienced in Maryland in particular, if you look at the fact that African Americans are 31% of the population, but they actually comprise 40% of those people who have died from it, you can see that there's an inequity there. And the reason that I say an inequity is because in public health, we're looking at this and saying pre-existing conditions are what are driving the death rates that we're seeing for African Americans. Well, those pre-existing conditions are not because Black bodies are broken. Those pre-existing conditions are primarily because of the social determinants of health and the policies and structures we have put in place that make it almost impossible for people of color, and particularly African Americans, to achieve their best possible health. But in addition to that, if you look under Hispanic, and you see that Hispanics in Maryland are supposed to be 10% of the population, but they're 21% of the cases, I believe that that is actually a reflection of where they work. So while many of us were able to shelter in place and work from home, many folks in the Latino community didn't have that option and were out in spaces that put them at additional risk, in addition to them having pre-existing conditions. Next slide. Now, what's really bothersome about this, and you may not have noticed it on the previous slide, there was no category for Native Americans on that slide, and it blew my mind. In fact, there was just a column that said other. And so I went on a little bit of a hunt, and what I found is that 80% of health departments have put out data, racial data, with regard to this crisis. And of those states, almost half did not explicitly include Native Americans in their breakdowns. And I actually believe that this is a reflection, this idea of otherizing a part of our population. It's a reflection of the fact that we don't necessarily value people of different identities, and certainly Indigenous people, in the same way that we do other people. Next slide. So what do we do? How do we build the bridge to equity? Because the reality is we can't stay where we are. We have to get to someplace else. Next slide. The fact of the matter is that in the United States, for the past 50 to 60 years, we have invested a tremendous amount of money to try to build that bridge. And the way that we've tried to do that is through diversity, inclusion, and cultural competence. And you probably rolled your eyes when I said cultural competence in particular. But the fact of the matter is, although we invest $8 billion a year on training and trying to get us to build that bridge, we've actually built a bridge to nowhere. So are we in the same place we were 50 years ago? Absolutely not. But are we where we need to be? Absolutely not. Next slide. A quick example of this, if you look at this McKinsey data, is this. This is a pipeline that speaks to corporate talent by gender and race. And at the entry level, you'll see that white men represent 36%, and women of color represent 17%. But then when you follow it to the right and you look at the C-suite, white men have gone from 36% to being 68% of the C-suite, while women of color go from 17% to being 4% of the C-suite. Next slide. So in essence, for you to go into a C-suite space and find a woman who's a person of color and a CEO is the same thing as you looking up and seeing one of these walk into the room with you right now. They hardly exist. Next slide. So the reality is, for all of these investments in diversity and cultural competence, we can be culturally competent when we're not diverse. When everybody's the same, it's very easy to be culturally competent. We can be diverse but not inclusive. I think many people experience that when you're not a part of whatever the dominant identity is. But the reality is you can be culturally competent, diverse, and inclusive, but fail to be equitable. Next slide. Because equity requires us to provide all people with fair opportunities to achieve their full potential, right? So even when you take it out of the space of health per se. Well, when I put this up on the screens around the country, where people get stuck is on this concept of fair. And in fact, people will push back and they'll say, you can't measure fair. It's subjective. It's a matter of opinion. I disagree with that. Next slide. So here's my response to that about what is fair. Fair is not what you think it is or what I think it is. Fair is whatever is necessary to get a person, a family, a population, a community to its best possible outcome. That's what's fair. And what that means is it's different for you than it is for me. It's different for one population than it is for another. But fairness is absolutely something that we can measure and we can quantify. Next slide. So in order to do that, part of what we have to do is to apply an equity lens. And this is the lens through which you view conditions and circumstances to understand who experiences the benefit and who experiences the burden of policies, programs, and practices. And this is critical if you want to engage in what we talk about as equitable leadership. Next slide. Equitable leadership requires the application of the equity lens as well as power. Next slide. So it's critical for us in our roles to understand what power really is. And power is around this ability to define reality for ourselves and for others. In a leadership role, we do this every single day through our decisions, our behaviors, and our actions. Next slide. So what's a nonprofit leader to do in the age of COVID-19 coronavirus? I've been asking myself that question as somebody who leads a nonprofit organization and has had to make difficult decisions. Next slide. In the midst of a crisis, we certainly can see ourselves, and this is the nonprofit life cycle, end up in a state of decline. We can end up not being here anymore. Or we can try to make decisions through an equity lens that can allow us to go back into a space of growth. Next slide. I don't know about many of you. I know for me, we certainly experienced funding cuts that precipitated a lot of decisions that were difficult to make. But we did that through the lens of equity. So any decisions about remote work or about salary cuts or anything else, we were always asking ourselves the question, who was experiencing the burden of that? And was that fair? And how could we share that burden? Programmatic change is the same thing. Who needed us the most? Where did we need to show up the most, right? And what did that mean with regard to benefit and burden? So now, that the restrictions in the state are being lifted, I think the question for nonprofit leaders in Maryland is around how will you restart your work, expand your work again with equity in mind. Next slide. I want to encourage you in order to do that as we begin to re-engage and figure out how to navigate coming out of this quarantine time and our organizations being scaled back, to think about what it means for you to develop a community of practice that focuses specifically on being equitable. And that means having those difficult conversations about who's experiencing benefits and burdens with regard to your internal decision-making, as well as how you deal with communities, and as well as your interpersonal interaction. Next slide. So as a part of this and as a part of being an equitable leader, it's important to make a commitment to continuous education. So I want to encourage you to do a couple of quick things before I wrap up. One is, if you have not taken it, take the implicit association test. As leaders, if we are walking around with implicit bias, it will get in the way of equitable decision-making. Even if you've taken it before, it can change over time, and it's important to understand how that bias can be in the way and to do the work to move it. The second recommendation I would make is to read Ibram Kendi's book, How to Be Anti-Racist. I think this is about taking action in order to truly be an ally as opposed to just saying it. I've also recommended a couple of articles here that I'll make sure there's access to when I'm done. Next slide. So the takeaways. Next slide. Identity matters to your life experiences and health outcomes. So you can try to make every good decision possible. But if systems and institutions are aligned in such a way that it limits your access, then ultimately you're experiencing inequities that will show up in your health. This is what we're seeing in the midst of this pandemic. The data about inequities tell us that the changes that we need to make have to happen at a policy and a practice level, but also within our culture. And understanding the historical context of how we got here is critical to getting us out of this space and time and finding a pathway forward and building that bridge towards equity. Next slide. So the key here, when you start talking about equity, people will push back and they'll say, oh, you know, there's no such thing as equity or fairness because fair is subjective and it can't be measured. Remember, fair is not about what you think it is or what I think it is. Fair is whatever is necessary to get a person, a family, a community, or a population to the best possible outcome. That's what equity is about, and that's what fairness is about. And as an equitable leader, I have, you have, we all have a responsibility to apply an equity lens to understand who's experiencing the benefits and burdens of policies, programs, and practices, as well as our individual decisions, behaviors, and actions. Next slide. One of the key pieces to this is this idea of you leveraging power to create equity. And remember, power is about the ability to define reality for yourself and for others. Every single day we make decisions that define reality for ourselves and for others. How can we do that with equity in mind? It has to do with the application of the equity lens. Next slide. So with that, I'm going to say something that I hope leaves you with a level of discomfort, but something to think about. Next slide. Many of us who work in the nonprofit space are driven by our good intentions. We're good people, we're well-intended, and we've chosen this path because we want to make a difference in the world. But the reality is, I've spoken to people, for instance, who work in the foster care system. They look at the data and they see that for 30 years, nothing has changed. That for children of color, for instance, in foster care, nothing has changed, and in some instances, things have gotten worse. So the question that I have to ask, and I'm asking you to ask yourself, how can you make sure that your impact exceeds your intentions? Because you'll never save a life through your intentions. I don't want the firefighter to show up at my house who's well-intended. I want the firefighter to show up who's going to make the impact. As nonprofit organizations in the age of COVID and in the age of these blatant inequities, we have a responsibility to hold ourselves accountable, not for our good intentions, but for our impact. Next slide. If you have any additional questions or so on, feel free to reach out to me. I am available and love to talk to folks about this important work. Thank you.
Thank you, Natalie. I know that there are a lot of questions and we're ready to, we're going to take them on at the end of this session. Kerry, would you begin, please?
Yes, thank you so much. So again, I am speaking on behalf of Native American Lifelines, a Title V Urban Indian Health Organization, and I'm going to speak specifically about our community as Native people. I don't claim to represent all tribes, all the diversities within our community, but speak for myself and for my community. So slide, please. Next slide. So just a bit about what we do at Native American Lifelines. As I mentioned earlier, Native American Lifelines is funded by the Indian Health Service in part to fulfill trust and treaty obligations that the federal government has with Native tribes. And if you think of it this way, it's that our people paid in advance for healthcare and other benefits through giving away our land or having our land taken away from us, however you want to look at it. And our ancestors made treaties with the federal government that entitled these things, entitled us to have these things. It wasn't until the 1970s that Native people living outside of their reservation communities had access to the healthcare services that were promised to us through treaties. At this point in time, over 70% of Native people actually live outside of our reservation communities. But I think the general perception of most Americans, which is highly informed by stereotype, is that the majority of us live on reservations. And some people have even asked, you know, if we still live in INEQUITIES. I do not, I live in a stone house. There have been a series of federal government policies that have moved our people around like pieces on a chessboard, and primarily because people, not ourselves, wanted our homelands. And so, you know, whether it was boarding schools or the termination of our tribes or the relocation policies of the late 1940s, 1950s, Native people have been moved about quite a bit, such so that in 1970s, while other civil rights movements were happening, Native activists argued that we should have access to healthcare services that's culturally appropriate for us, and again, that is promised to us. So that's when the Office of Urban Indian Health Programs was established in the 1970s and funds programs like mine, which are part of a network of about 44 urban Indian health programs nationwide. Native American Lifelines operates in Baltimore, Maryland, as well as in Boston, Massachusetts. So our mission at Native American Lifelines is to promote health and social resiliency within our community. And to do that, we apply principles of trauma-informed care that provides culturally centered behavioral health, dental, and outreach and referral services. So basically what that means is that we don't provide direct medical care, but Native people can reach out to us and we will connect them with care. We can help to pay for that care. But the largest part of what we do is health education, health promotion, disease prevention within our community. And so in order to do that, we subvert the traditional paradigm, which Natalie kind of mentioned, cultural competency, that sets my teeth on edge. And basically, I have, let's say, a brochure about HIV, and I may put kente cloth on the cover, and that's for the African American community. I put a serape on it, that's for the Latinx community. I put a feather on it, that's for the Native community. But nothing inside that brochure changes. The information is the same, so it's not really speaking to me. It's just giving the illusion that it is and ticking a box that I've been culturally competent. So as a medical anthropologist, what I'm concerned in is the place where culture and health intersect. And that's not just the type of health care that we choose to receive, but it's the way we conceptualize what makes us well, what makes us unwell, as well as any of the cultural, political, and historical forces that shape the way that our community can enjoy health or not. And so a big part of doing that is to start with Native culture first, to privilege our stories, our teachings about health and wellness, and then to weave health information from a Western perspective on top of that. And that is part of us being trauma informed, that we are very sensitive to the historic trauma that our Native people have faced, and I'll unpack that a little. Next slide, please. Thank you. So start with a definition of who an urban Indian is. I'm often asked, you know, what is the preferred term? Native American, American Indian, Indigenous. That's really a highly personal thing. When Native people, when we're talking amongst ourselves, we typically identify by our tribe first. But my grandpa said American Indian. I tend to say that. So it really is just very personal. But urban Indians are any of these three groups. We may be tribal citizens, so we're enrolled citizens of federally recognized tribes like the Navajo or the Lakota or the Anishinaabe, or members of state recognized tribes like the Piscataway Conoy here in Maryland, or the Lumbee tribe of North Carolina, which has a large community here in Baltimore. Or we are descendants of either of those groups of people. The part about descendants leads me to the next point that I think is important to make, that it's incorrect to think of American Indians, Alaska Natives as just a race or just an ethnicity. That actually refers to a legal identity that we have. So again, our ancestors engaged in treaties with the federal government. Federally recognized tribes are seen as sovereign entities, and so we have a government-to-government relationship with the United States that not everyone else enjoys, just predicated on race. Tribes get to determine who is or who is not a member. And oftentimes that membership is looked at through blood quantum. I have a friend who often points out quite correctly that the only people who have to, or not even people, the only beings who have to prove that they are who they say they are dogs, horses, and Indians. We have to have a card to say that we are an enrolled member of our tribe, or in the eyes of the federal government, we are not Native, even though that's the family that we come from. So we can see if a tribe, let's say, has a blood quantum of 1/4, in one generation, someone can be born going from being a tribal citizen in the eyes of the federal government and entitled to certain benefits and to not. So it's really important for programs like mine to exist to serve these individuals, but it's important when we're thinking about who is and who is not a Native person to understand that that really goes beyond just race to say who we are. Next slide, please. So some of the concerns that our community has with regard to equity, and I apologize, of course, of all days, my allergies are off the charts. I've mentioned those trust and treaty obligations quite a bit. So again, if you think of tribal nations as governments like Mexico, like Germany, you know, the United States has a very specific relationship with the government itself and not just its citizens. So in the instance of COVID-19, that is a place where you'll really see sovereignty becoming an issue. Tribes, and again, the majority of Native people live outside of their reservation communities, funding goes to that tribal government. It doesn't go to urban Indian organizations like mine at the same rate that it does to tribes because of that sovereign relationship. And so what you see in a situation like the Indian Health Service, for example, if again, we know that 70% of Native people live outside of reservation communities, the IHS budget only directs 1% of its total overall budget to urban Indian health programs, which is where the majority of our people live. So that is a structural inequity in funding right there that can really under-resource Native people. It is my firm position that your status as a tribal citizen doesn't change just because your zip code changes. And so I hope that we work towards a situation where funding follows the individual Indian person. Impacts of historical trauma. Those really are at the heart of the work that we do and really can color the extent that someone has wellness or does not. I mentioned earlier that I'm a descendant of a boarding school survivor. So my ancestor was taken from his reservation in Montana and brought to the Carlisle Indian Boarding School in Pennsylvania, where he was not allowed to have his name. He was not allowed to have his language. He was not allowed to have his spiritual practice or any of the things that made him who he was as a Lakota Nakota person. And so when these things successively happen, that was something that Natalie talked about, the stress that our people feel. Imagine being a young child and being taken by train across the country and being told that everything about you is fundamentally wrong. And you grow up to believe that about yourself, and that's what you teach your children, and that's what their children learn. And so it's very difficult to have health in that way if what society communicates to you historically is that you are of no value. And I think that we see that in the data. We see that in our interactions with medical professionals. I am a very light-skinned person, so I may have somebody ask me why I have blue eyes, how much Native I am. And those are questions that aren't typically asked to other group of people, like how much Asian are you, or, you know, just questions like that are very microaggressive and dehumanizing. And so, you know, our people tend to shy away from traditional medical institutions because we're treated in that manner, but also because of the way that our people and our bodies have been treated, even through the Indian Health Service. I think it's It's well known in our community, and I'm not sure in other communities, how our women up until the 70s, 80s were sterilized without consent. I had an auntie who went in for a cough and came out unable to have children. And so if that is your experience with healthcare systems, it makes sense that you aren't going to engage. And so we see that we are overrepresented in poor health measures, type 2 diabetes, hypertension, obesity, all of those things right now that we look at as underlying causes that can really determine how you will fare if you're exposed to COVID-19 are very highly expressed in our Native community. And again, we are not accessing healthcare in the way that we should. In Maryland, Native people in the Baltimore area typically didn't have access to healthcare until the Affordable Care Act was passed and Medicaid expansion happened. And so there's sort of a pattern of using the emergency department as your primary care provider. And right now, within the COVID-19 environment, we know that that is the worst way that you want to engage in healthcare. We also see a lot of substance abuse and poor mental health outcomes in our community. And so that creates a level of brokenness in our communities where there may be whole generations of our people who are gone. And that's not just bad health, that's not passing down the stories, our origin stories, our languages, children having naming ceremonies. Again, very important parts of our resiliency as Native people. And so what we try to do in our program is, if we start from the place that what makes us unwell as Native people is the things that we lost, the historical trauma that we face. The way we try to repair that is to bring those things back in the way that we approach health. So using language, using symbols that are important to us. And that's just kind of the way we do what we do. Data and visibility, again, Natalie referred to us, you know, up until recently, if I wanted to test for HIV in Baltimore City, I could be white, Black, Asian, Latino, or other. And that has recently changed, but only because of our community creating a relationship with then Health Commissioner Dr. Wen and then HIV Bureau Chief Dr. Patrick Chalk. If they weren't willing to engage in a relationship with our community, it might still be that way. So now, for the first time, and only in the Ryan White program, are we able to get some data about how American Indians, Alaska Natives are faring. But that is if they ask us. Again, healthcare professionals will often look at us and make the determination as to who we are. And again, my very brown grandpa on his death certificate is listed as white. So we are underrepresented in data. And why this is important is, particularly now as we try to wrap our arms around what's going on with COVID-19 and its impact in the Native community, we're simply unable to do so. Next slide. Okay. Again, Natalie mentioned some data that I had actually written down to share with you. So if we know in the state of Maryland as of today, of the confirmed cases that there are in our state, 11,140 are members of the Black community. And then the third highest case is non-Hispanic whites, which is 7,367 cases. But then if you combine the other and the data not available, that's 8,133 people. That is the second highest group of people who are impacted by COVID-19. Who are those people? Wouldn't you want to know? I want to know. I want to know if they're my community members. When we look at Baltimore City data, we see that the highest, one of the highest places in Baltimore City where there are COVID-19 cases is zip code 21224. That is where the majority of Native people in Baltimore City live. And we know in a nonprofit environment that data equals dollars. So if my data is not showing up, then anyone who's choosing to make funding decisions is going to say, well, there's no problem here. Well, why should we fund that? And that is definitely an issue. The other issue is whether or not our people can get tested at all. Native people who come to cities from reservations typically are engaging with the Indian Health Service, and they're pretty much able to get what they need here. But despite the large population of Native people in the state of Maryland, and remember the Indian Health Service is headquartered in Rockville, Maryland, and also the state of Maryland is home to a lot of Native people who may work for the federal government. There are no ambulatory services that are specific to Native people in our area to fulfill that trust and treaty obligation. So right now, we are only able to refer people for testing, and it's very difficult to access. And we don't necessarily know who is being tested or what their results are. The only way that we have that information is by reaching out to our community. And so one of the benefits of being a small program and how we've responded to COVID-19 is that we've contacted each person of our over 700 active clients to find out what they know about COVID-19, find out or make sure that we're educating them about prevention, and then finding out just sort of what their concerns are. And one of the things that has surprised me is that in our community, you are less likely to hear that people are concerned about contracting COVID-19. What they are worried about is, how am I going to feed my family? How am I going to get toilet paper? How am I going to pay my rent? How am I going to pay my gas and electric? Those kind of kitchen of life issues are exacerbated in a pandemic such as this. And when your community is already so vulnerable, it just makes that hole that you're in even deeper and creates a level of anxiety that is difficult on the well-being of our people. And the last point I wanted to make is just the social isolation that we experience. And everyone is going through it, but right now for us in Indian country, this is powwow season. And it is a time where we would be out and visiting with our relatives. A lot of our people are vendors. They go to powwow, they sell their jewelry, they sell their clothing. And that is a stream of income that is being lost to them right now. So you have a loss of access to something that's very culturally meaningful for you, and maybe the only way kind of in the society that you live in that your identity as a Native person is affirmed in a positive way. You don't have access to that, and you're lacking access to the money that you would make if you were able to participate in activities such as that. So, you know, this has been just a snapshot of sort of some of the problems that Native people are already experiencing, and the way that those problems are amplified by being in a situation such as this. So with that, I thank you for your time. Again, apologize for my sniffles, and I look forward to any questions that we might get. Thank you. Wopila.
Thank you, Kerry. Very enlightening. To make sure that we keep up with the time, I'd like to move straight to Andria Smythe.
Hi, everyone. So as we mentioned previously, I am a professor at Howard University in the Department of Economics. And what I want to bring to this webinar is just to highlight some of the structural issues in the economy that are kind of setting the stage of some of the outcomes we're observing right now. So the first graph, so let's move the slide along. So the first graph we're going to start with is the distribution of wealth in the US. And I'm starting with wealth because I think it's most important. Wealth is a means to an end. So we don't consume wealth itself, but we use wealth to purchase other goods and services. So in the sense of tangible goods like food and housing and education and healthcare, but also intangible goods like justice under the law and freedom and political influence. So this idea of distribution of wealth is so important to the outcomes we're observing right now. So on the graph, I want to show you just the distribution of wealth for different groups in the US. And of course, we can look at the top 1%, that's the red shaded area right there. The next 9%, that's the orange shaded area. So the top 10% of households in the US control close to 75% of all wealth. right? That's what we call wealth inequality. But I also want to bring your attention to the bottom 50%. So that's the shaded light blue area at the bottom. And as we see, that area is small. And between 2009 up to 2013, it did not even register on the scale. So wealth is just a purview of a small fraction of households. And then we can think about wealth in terms of race. So in the US, the last Forbes 500 wealthiest people show that the 300 wealthiest people in the US holds more wealth than all of the Black people in America, right? So just to kind of put those things into perspective, and remember, wealth is about what you can purchase with that wealth. Next slide, please. We can also look at income. And in this slide, I'm showing you the percent of national income that accrues to the bottom 50% of earners. So that's that green line you see there, and the percent of income that accrues to the top 1% of earners. And this graph is showing you these percents since 1962. And what we see is that the income going to the bottom 50% of earners is actually declining. And we see the opposite trend for the top 1% of earners. So not only are they disproportionately richer, but their riches are increasing at higher rates than the entire half of the US population. So next slide, please. So another thing in the context of wealth inequality and income inequality is about what you can purchase with these goods, with these income and wealth. And this graph is showing the change in prices for different goods and services over the past 20 years. So if we start at 0, we can see some of the goods and services where the prices have remained pretty much constant. So those include things like cars and household furnishing and clothes or whatever. But the top half of that graph shows the goods and services that have become more expensive. If you notice the goods that are represented here, things like hospital services, it's increased more than 200% in the last 20 years. So you understand for these low income households, it's more expensive just to access healthcare. The next is college tuition and college textbooks, so just college in general. And when we talk about what the role of the economy is, it's to improve the economic lot of its citizens. And college is very important in the sense of intergenerational mobility. Well, college is becoming less accessible over time, especially for low-income households. The next category of goods we see increasing in prices, things like childcare and nursery school, medical services, which of course, if we combine that with hospitals, kind of covers the healthcare sector. We also see things like housing and food and beverages. Their prices have increased over 50% in the last 20 years. So if you notice these goods, basic needs like housing and food, those prices are increasing. Access to healthcare, the prices are increasing tremendously there as well. And then college education, which has traditionally been the route to economic mobility, so people can improve their economic lot in life. Well, that is becoming out of reach for majority of US households over the past 20 years. Next slide, please. And this graph just shows you the degree of mobility. Again, the whole idea of having an economy that works for people is so people can do better than the next generation. And that's what this graph is showing. So we won't get to go through all of that, but let's just look at the solid lines here. So the solid blue line shows mobility patterns. So it's the percent of US children who earn more than their parents. So we see for the 1940s birth cohort, a solid 90% of children will earn more than their parents. Then if we look at the orange line, we see that mobility is actually declining. So this is a mobility for the 1980s cohort. So if we look at in the middle here, the median parental income, a person born in 1980, only say only 50% of those individuals will actually earn more than their parents. So the degree of intergenerational mobility is just declining at an unprecedented rate currently. Next slide, please. So this graph is showing you life expectancy. Again, the whole idea of even having an economy is so people can live a healthy life, a good life, and also a long life, right? So here I'm looking at life expectancy, and we're looking at the gap in life expectancy between high income and low income households. So the top line shows this gap between high income and low income for men. And we see that for men, high income men live about 11 years longer than low income men. And for women, it's about 7 years longer. But what this graph is showing is that low income individuals, and I'm not showing it by race, but these patterns do hold if we look at race. So high income individuals or low income individuals are already dying at high rates. The current COVID crisis is just exacerbating these trends, but they're already in the data. Every year we see these disparities in death. And again, remember, it's not just about the length of your life, it's the quality of life that you have while you're alive. And we know that quality of life is significantly lower for low income individuals. So this idea of low income workers and Black individuals more likely to die during the COVID crisis, well, this is happening on a daily basis, regardless whether we're in a recession, which I'll talk about in a minute, or whether we're in a pandemic. These patterns of death among low-income individuals is already observed. Next slide, please. And this just compares life expectancy for the US with other high-income countries. And we see for the US, in the 60s and 70s, we were kind of in the middle of the pack. And today, those countries are leaving us behind in terms of life expectancy. And again, these are average. This is the average. So we're combining both the high income and low income in these numbers. So overall, the US is doing worse off in terms of, and this is one of the quickest way we look at the quality of health in the US, and we see that it is declining even while we're paying more for healthcare. Next slide, please. And then, as I said, we can kind of cut all these numbers by race and by gender. And this graph just shows you the white-Black wealth gap. So we see for Black households, so this shows the median wealth for Black and white families. So the top blue line shows for white families, the bottom yellow line shows for Black families. And for Black families, they've never, for the typical family, they've never held more than $25,000 in wealth since 1989. And the gap is actually larger in terms of Black and white than where it was. Next slide, please. And then we can look at some of the disparities by gender. So this graph is showing you the top one shows the gender competition for the highest paying occupation. We see that those tend to be male dominated. And then the bottom chart is showing the gender composition for lowest paying occupation. We see those are female dominated. So, and then if we look at the type of occupations that are represented in the lowest paid occupation, things like childcare workers, host and hostess, personal aides, cashier, fast food counter workers. When you think about this in the context of the COVID-19 crisis, these occupations are either being laid off or they're at the front line of this pandemic. Next slide, please. So this graph is showing you the US unemployment rate. If we look at the right-hand corner, we see the line kind of spikes up. Those are the numbers for April. Right now, for women, it's about 15.5% unemployment. For men, it's about 13% unemployment. So women are getting hit more in this pandemic. But I don't want you guys to miss this. We are in one of the worst economic crises since the Great Depression. So for the nonprofits out there and food banks, we're going to see more people using that. Homelessness, we're expecting all of that to increase. And it's not just low income workers. pretty much every work along the income distribution will be impacted. So we have to be prepared to serve more people in the nonprofit sector, especially if the government response is not strong enough. But the thing is, it's the time when the need is greatest. That's when funding tends to be lowest. So if we don't have appropriate responses, this can get really painful for a lot of people. Next slide. And I'm going to end with this graph. And again, it's to kind of show you these disparities in outcome. And remember, we talked about majority of the income already accruing to the highest income earners. Well, if we look at this pandemic specifically, for example, this is showing for each 20% of households, whether the percent that can work from home or the percent that stayed home from work and unable to work. So for the bottom 20%, the bottom quintile, 41% work from home. For the top quintile at the right side of the slide, 71% is able to work from home, right? And then 45% of the bottom quintile stayed home from work, unable to work. And for many low-income workers, if you don't work, you do not get paid. And then for the top quintile, only 19% stayed home from work, unable to work. And they're more likely to have savings and wealth to fall back on. So this outcome that we're observing in COVID-19, it is just a feature of already unequal structure of the economy. So I just wanted to highlight, of course, there are so many different ways we can look at we can look at these inequities by race, the wealth gap, and by race, the income gap, just the slow growth rate for low-income workers over time. And we just ended one of the longest expansion in US economic history. And it was only until 2019 that low-income workers started to see any significant increase in their wages. So, and a part of it is if we leave it up to the market, it will not solve the issue. A lot of these outcomes are actually policy choices, and we can make different choices. That would be my takeaway from this panel. And I'm glad to answer any questions you guys may have once the presentations are over. Thank you.
Thank you, Andrea. We're going to move on to Fagan. I'd ask the panelists to pay attention to the questions in the Q&A in the chat, and we'll get to as many as we can. Well, let's hear from Fagan. Fagan, I know you've got a personal story, and then you can tell us what's going on with Baltimore Core.
Yeah, thank you. Good to be with everyone this afternoon. I was diagnosed with COVID in March, so I'm just going to kind of walk through the timetable and my experience with the illness and a few reflections on ways that illness is stressing our communities, particularly communities of color, and also the institutions that serve everyone. In early March, on March 3rd, I had jury duty down at the Mitchell Courthouse in downtown Baltimore. I sat next to a woman who was quite ill and was kind of sneezing and coughing, and we just kind of struck up a conversation and spent the day together over the course of jury duty that afternoon. Wrapped up my week. That was really the last time I was out in public, and by that weekend, I'd say by the 6th or the 7th, I started to feel like I had caught a cold. By March 10th, I had what I thought was a full-blown case of the flu. It was notable to me, and I remember that day in particular because I had a full work day and I felt disoriented. I felt confused. I did something I've never done in my life. I showed up for a meeting that was at 3 o'clock. I showed up at 10 o'clock. I just misread the calendar and was kind of borderline hallucinating a little bit. And when that mix-up happened, I realized, man, I might need to just go home and kind of ride this out. And so I started kind of isolating at that point. And there'd been enough in the news about COVID that I started thinking, well, maybe I've come down with the COVID-19 virus. Those flu-like symptoms lasted about a week and a half. I isolated and self-quarantined at that point. Started to feel better by mid-March. Had thought I'd turned the corner, and at that point had kind of chalked it up to a bad case of the flu or a seasonal bug, when the week of March 17th, I started having some respiratory challenges and had trouble breathing, and that got progressively worse, so much so that by March 19th, I woke up and it felt like I had an elephant on my chest. And I got up to try to go to the restroom, and I couldn't make it from my bed to the bathroom 20 feet away without feeling like I was going to pass out. Like I was having a very hard time oxygenating. And so at that point, I went to the hospital. I went to Chase Brexton, which is close to where I live here in Baltimore City, got seen and got tested for COVID-19, got diagnosed with pneumonia at that point as well, was told to go home and again, continue to isolate while we awaited the test result. And by the 21st, I had come back with a positive test for COVID. And so this is where it gets, I think, really interesting, because I'm really struggling to breathe at this point. Chase Brexton basically said, like, look, we can get you the test, but we don't have great guidance on how to deal with this. So we actually don't have any drugs we can prescribe. You're just gonna have to kind of treat the symptoms, and you're borderline on your oxygen level. If it gets any worse at all, we really ought to put you on oxygen and send you to a larger hospital to do that. And so I opted to go home and was told by Chase Brexton to call the University of Maryland, that they had kind of better facilities, more robust facilities for dealing with this, particularly the pneumonia piece. Called the University of Maryland, informed them of my situation, had been told by Chase Brexton the University of Maryland would be expecting my call because it was a referral, and University of Maryland turned me away cold. They said, you know what, we can't deal with this. We understand you have COVID. Please don't come in. And so at that point, I was pretty frustrated, was pretty stuck, and just started basically kind of crowdsourcing medical intelligence from friends I have in the medical field across the city, across the state, and across the country, and kind of pulled together a regimen of what I thought kind of made sense and would work. And basically that just subsisted off staying very hydrated, making sure to keep my appetite up, despite the fact that I can't taste anything at this point. I don't really want to eat, but it was incredibly important to continue eating. And so spent the next 10 days at home in complete isolation, kind of making myself eat 3 square meals a day, drinking probably every 15 minutes, as close to 24 hours a day as I could for as long as I was awake, and then just sleeping. And gradually it got better after 10 days. And at the end of it, I had lost almost 20 pounds, despite kind of consuming that many calories over the pace of it, and really not moving around that much because I'm isolated at home, spending most of that time in bed. But my kind of takeaway from it was, your body is working so hard to try to overcome it. It's marshaling such a kind of robust immune response. It's working overtime. And the virus is very good at stripping away kind of your taste and your desire to eat and making you lethargic. And the risk is that it overwhelms your immune system response, and then kind of your lungs and your cardio system starts to shut down. And so I was very borderline there. And until I really almost adopted a military-like mindset on kind of calorie consumption and fluid consumption, it was absolutely winning. I think the kind of hospital guidance, obviously our hospitals are overwhelmed. And that's so much of the logic of social distancing, is to kind of give them time and space to catch up. But I was struck that the misinformation from the federal government, the lack of care and coordination from the federal government, kind of the speed with which this virus has moved, clearly overwhelmed our local systems and institutions, to the point that when I got ill in March, they didn't even want to admit me to the hospital. I think that's changed quite a bit, but I would share kind of, we work really intensely with communities of color, and I've heard these stories time and again now. We're seeing overwhelmingly a lot of people of color dying at home because hospitals don't take their symptoms seriously, because they won't get admitted and they won't get treated in a timely fashion. And so while this is kind of harsh truth to speak, I believe in it so much. You have to be your own advocate, and you have to organize advocates around you, and you have to make sure that you have all the support to really agitate to get the care that you need and you're entitled to. Because if you don't, the combination of the institutions, I think, being overwhelmed by the shape and character of this virus and its speed and its volume, coupled with the implicit and explicit bias we know exists in our society and across our healthcare system, that can really combine to create a really inferior experience with healthcare at a time when we can ill afford it. And so, look, I make no bones about it. I'm a really lucky person, and I have a great job and I have a lot of privilege, and it was still extremely hard for me to get what I needed to survive this and overcome it. And so I can only imagine folks who are maybe raising children alone or juggling multiple jobs that maybe are less permissible for them to work remotely or to kind of take time off, et cetera, just how challenging and difficult this can get. And so you have to bring almost a warrior's mentality to your own healthcare when you engage these systems, and then also making sure you're doing what you need to do to stay fortified to survive and fight the virus. And I know we're coming up on time, so I'm going to end my kind of comments there. Happy to address more in the Q&A. I would say very briefly to close, our organization, Baltimore Core, is doing a lot to staff the city's response to the pandemic. We understand that there's a massive jobs crisis now in our country and in our city. We are literally filling hundreds of jobs at Baltimore Core in care coordination, contact tracing, frontline roles, delivery roles, capacity roles, administration, managerial. From the entry level to the C-suite, we are recruiting and enlisting people to do something about this crisis. And so if you or someone you know is looking for work, you can find us at Baltimore Core, corps.org. And we'll try to connect you to opportunities we know are coming online.
Thank you, Fagan. We appreciate that. Anjaniki, could you help us out with questions? I know that we're coming up on time. We probably got just a few minutes to ask the panelists to answer a few questions. I know panelists, you've been answering in the Q&A. I know there was one question. Go ahead.
Yeah, I think that maybe we should ask the panel to speak about just a general quick call to action, sort of right now, here as a person on this session. What would you recommend that I what would you recommend that I do? I want to move to the call to action, I think, because I know we're supposed to end at 3:15. Okay. If it's okay, Carmen.
That's fine. That's fine. So panel,
and then after that, we can open up for Q&A again for people who have time and would like to continue.
Okay. All right. So let's ask each panelist if you would give us your final takeaway. One thing that people can do, either individuals or communities or organizations can do to bring about change. Let's start with Natalie, however you want to address that. And then once everybody has a chance, then we'll circle back to the questions.
Sure. I think it is critical in a leadership role to do the self-work, the introspection, not only to combat and dismantle our own biases, but also to really be students throughout the course of our lives as it relates to these issues around equity. Nobody is so woke that they can't learn. And I do sometimes get concerned about that. So we have to challenge ourselves as we begin to understand how the society devalues certain identities, to be open to learning more about those identities, and then making sure that we are asking that question over and over again with the application of the equity lens about who is experiencing the benefit or the burden of the decision I'm making, the behavior I'm engaging in, or the action that I'm taking. I think as organizations, we're at a very critical time, and it creates an opportunity for us where either we can continue to do business as usual and fail to have the impact that we need to have, or we can actually take this as a moment of opportunity because the inequities are so glaring that even those who want to ignore them have no choice but to pay attention to them. The question is, how do we choose to show up? And I think we show up by putting equity front and center and making it clear that fairness is not an option. It's not an option from a human level, and it's not an option from an economic level.
Thank you. I know, Fagan, you have to leave at exactly 3:15, so I'm going to ask you to give us your final takeaways.
Thank you all so much for organizing such a thoughtful and informative panel. This was fantastic. You know, I think the big thing that jumps out to me is that if we continue to maintain the false choice between the economic crisis and the public health crisis, we will see more economic damage and more needless, senseless death as a result of this public health crisis. The reality is that there are going to be massive job opportunities as part of the response, and we need to make sure that we have all of our communities included in the employment that's going to motivate and generate that response. We know that during good economic times, roughly half of people who find themselves out of work need to do some kind of retraining or reskilling to enter new careers in order to reattach to work. We know that the proportion of people that need to do that retraining and reskilling, that number spikes to almost 80%, if not 90%, depending on the severity of the crisis. That means overwhelmingly, in order to reconnect to work, if you just lost a job, you're developing new skills and entering new careers and new professions. And so I think in the world of healthcare, there will be tremendous opportunity to both make a difference in the shape of this pandemic, but also get a lot of people put back to work who are now looking at the bills coming due, looking at unemployment, collecting unemployment. We have to stop framing this as if it's about saving our economy or beating the virus. It's about aligning our economy to beat the virus and making sure we got as many people enlisted in that fight as we can. So we work very hard on that at Baltimore Core. The Mayor's Office of Employment Development is also doing a lot on that. You can go to either of those and find a ton of job opportunities that are coming online.
Thank you, Fagan. Let's go to Kerry next.
Hi. So I think from a human being level, I think we need to reconcile our relationship with this land and its first people. And particularly if you are non-Indigenous, you need to acknowledge that the land that you occupy is stolen land built by stolen bodies. And so having respect for those people who, you know, are often seen as the least of these, created all the wealth that this country enjoys, and so that we are the most under-resourced and face the most inequity, really means we need to recalibrate that relationship. I think from a program perspective, data collection is so important. So if you have the ability, just the same way that you will give people the option to indicate what their gender is, write it in, allow people the opportunity to identify themselves as American Indians, Alaska Natives, and then allow us the opportunity to tell you the tribe to which we belong or descend from. Again, I can't state enough how important data collection practices are to our community, and it's a simple thing that people can do. Thank you.
Thank you, Kerry. Andria, your final takeaways?
Mine will go back to, you know, tackling the structure of the problem. So of course, when there's a crisis, it's more in your face and people are seeing it, but these are things that are observable and are there in the data. Even when as I mentioned, we were in the longest economic expansion in US history. We knew that low-income folks were not doing well. We knew that Black folks were actually declining in wealth. Home ownership rates were actually falling. So if we can actually lobby for policies that gets the structure of this issue. So when we talk about access to healthcare, universal healthcare, we talk about things, healthcare should be a human right. Don't fall into the pattern of saying, oh, that's socialist thinking. No, we're thinking about saving lives. Things like access to high quality, affordable education. So as Fagan mentioned, with people who need a skill are able to get the skills they need so that they can participate in the work world. And just policies that help families to build wealth so that when there is a crisis, they have a cushion to fall back on so that they're not dying at disproportionate rates. And the whole idea is if we have the structure of the economy that is sound, we are able to weather a crisis without going into these death spirals for low-income groups.
Thank you. And Janicki, let's go to the questions now. Let's see how many we can get in.
Yes. What is the first question that got an upvote here? What is a good comparative between cultural competence and cultural affirmation?
Who wants to take
So I
that?
think I'll give it a shot. I think I've also just tried to respond to this in the chat. So cultural affirmation, I think of it as a muscle of cultural competence. It's the way to apply cultural competence. But I actually find it to be problematic. Cultural affirmation, similar to inclusion, gives the power to the person who is affirming or who is including, right? And so I am buying increasingly into the concept of belonging. Because when you belong, you don't have to wait for anybody to affirm you or include you. And I think there's a big difference there. I think the idea behind cultural affirmation is well intended in the sense that it's this idea of I see you, therefore you exist and I am, you know, like sawubona, that type of thing. And I get it in that way, but in this society in particular, power dynamics are too important for me to ignore that, right? So I think we should strive more towards this place of belonging as opposed to affirming.
Thank you. Antonika, go ahead, please.
I just wanted to add, in the Native community, we also tend to use the phrase cultural humility. So, you know, assuming that your way is not, you know, understand that your way is not always the right way, and there are differences, and having a humility, or, you know, not going into a place and just because you work with a people, feeling like you're an expert. For example, I did a lot of work with the transgender community, but I am not a trans person. And so I can work with that community, but I should never confuse that I am an expert or speak for them in any way. So being humble is important.
Thank you. There was another question, Anjaniki, what can be done to combat the structural racism people of color experience in medical care, such as the lack of doctors, facilities in their communities? I think Fagan touched on that. Either of you want to talk about that? Anyone?
Okay.
Go ahead. Okay. Any panelists want to take a crack at that? Well, we know that, go ahead.
Can you repeat the question?
Sure. What can be done to combat the structural racism of people of color, that people of color experience in medical care? For example, lack of doctors, medical facilities, yeah.
Sure. Kerry, unless you want to go first, and then I can go, either way. Okay. So racism, isms in general, but racism in particular, is a reflection of the fact that we don't value people of those identities. And the reason that we're able to do that is because we are not in relationship with them. And so one of the things that I believe strongly is that the inequities that we see reflected in society is a manifestation of a culture that has been cultivated that takes us out of relationship with one another. And I'll take it a step further. Human beings are hardwired for fairness. And people will say, what? That can't be true. It actually is true. But that fairness was built upon this idea that we were interdependent. My very survival was dependent upon your survival. My ability to thrive was dependent upon your ability to thrive. And so what we did was to dismantle interdependence, to dismantle relationship from one another, from nature, right? From spirituality, et cetera, et cetera. And that part of our brain doesn't fire up the same way. So if we want to begin to tackle this idea, this reality actually of structural racism, we have to begin to look at how do we put people back in relationship. I believe that that goes from everything from microeconomies to proximity in terms of how we live to and with one another. There are a host of things that we need to do that are about restructuring interdependence based on the core of who we are as human beings. Because when we're in a relationship like that, the isms become a lot harder to engage in, and they also become a lot more obvious to us.
Thank you.
And I want to echo Natalie's point. There's a saying in Lakota, "Mitakoyo yasin." It means that we're all related, and not just human beings, but I'm related to my environment around me. And if I see everyone as a relative, I mean, you've got that one cousin always who's kind of weird, but if you love all of your relatives and you treat all of the people that you encounter as relatives, then that's going to guide and direct how you interact with them. There are also, and I'm sure Native culture is not the only one, but there are a lot of teachings and prophecies about how when our world comes out of balance, and loses that interdependence, and any of our people have more feel that they are more elevated than another, then that's where we have a lack of wellness. So those things are really important. And the last thing I want to say, just in terms of institutions, if you are a person of color, mentor and uplift another person of color so that they can occupy those roles, so that, you know, we see each other's faces and we support and elevate one another, to be in there doing the work that will serve our community in a good way.
Thank you. You have
and
been.
Carmen,
Yes,
may I add one thing before you go?
Absolutely.
If I
Oh,
don't.
yes, sure.
Particularly as it relates to medical care. I mean, it's been clearly documented, especially if you think about just pain management, that clinicians hold a bias and myths about how people of color experience pain. Everything down to thinking that you know, our skin is thicker and that we can tolerate more pain, and that when we're asked to rate our pain, that we exaggerate, and that our white counterparts, in fact, can't tolerate pain, and that, in fact, they are understating their pain, that we're more inclined or more likely, people of color, to get addicted than our white counterparts. And it's that bias and those myths that, combined with the work of the pharmaceutical industry, led to the overprescribing of opioids and drove white America down this path of what they now define as an opioid crisis, right? And led them into depths of despair, so that we are now seeing that white people in middle age between 45 and 55 are dying at a higher rate than their counterparts. Who would have ever thought we would have lived to see that? And so the point that I want to make in it is this: too often when we talk about issues of racism, we speak about it as though the only person or people harmed are the people of color. Racism robs white people of their humanity, and privilege is killing the privileged. A persistent state of racial privilege makes you less resilient. It makes you less capable of dealing with adversity. That's part of what happened with the opioid crisis. And so while it may feel good while it's happening, that privilege, that persistent privilege, the reality is that floating on your back doesn't allow you to develop the muscles that you need when you need to tread, right? So it doesn't mean that you're not in the water, but it certainly doesn't prepare you for the worst of conditions, right? So I think it is important when we have these conversations about racism that we also make the case and make it clear that white people are being robbed of their humanity by engaging in systems and institutions that are perpetuating racism, and you cannot swim in dirty water and expect to be clean. So it doesn't matter how good of a person you are, right? And ultimately, that robs us, all of us, of this opportunity to have our best possible lives. I'm gonna stop because I'm about to keep going.
Oh no, we can keep you all day. We can keep all of you all day. I mean, but wouldn't it be a rich conversation if we could have this level of authenticity with white men, with folks from other cultures, and we're going to aim for that, because we are interdependent, and it may not feel as if we are, but we're one people, one planet. I heard that somewhere, right? But we really do need each other. Andria, is there one last question, and then we're going to close out?
I think I just want to ask this question out loud, because maybe it wasn't easy for people to follow in the chat. But this is for Kerry. Could you describe a powwow and what the role and purpose of a powwow is currently and how they're organized? And have you planned a virtual powwow?
So powwow is one word. In Lakota, they're also called wachipis. It means they dance. And, you know, when you remember historically that people in winter camped separately, in summer they came together, those were times of social interaction. Now they are more for dancing. Some are competition powwows, but they're places where you see relatives, or you know, you support Native vendors, you eat Native food. What a powwow isn't is a meeting or a quick chat. that you have with a coworker. And when Native people hear that, very many of them get very upset. Terms like, let's have a powwow, you're a low man on the totem pole, or, you know, they said something crazy, they left the reservation on that one. Those things are really not appropriate to say, but they're part of a common lingo. So I would just encourage people to be mindful of those things.
Well, thank you, everyone. I hope you know that you have a standing invitation. This won't be your first time. We'll be bringing you back. That we need to plumb the depths of many facets of these conversations. I am sure that our listeners have and viewers have gotten a lot from this. This will be, this has been recorded. It will be available soon after our conclusion of this event. Again, on behalf of Maryland Nonprofits, Care First, our board and team, thank you, each and every one of you. You're amazing. And I could talk to each of you all day long. So please know that we'll be in touch and we hope to see you again. Thank you, everybody, for listening. This is Carmen Marshall from Maryland Nonprofits. Have a good day. Safe.
Thanks. And panelists, can you all smile? Hold your smile for a moment. I'm going to take a picture.
Oh, Heather, there you are.
I still keep holding. Sorry, the snipping tool is tricky. There we go. That looks good. Thank you all
Heather,
so much.
Heather, since you're there, did you want to have a word before we sign off?
Do I?
Oh, Heather Iliff, our CEO. Go ahead, Heather.
Thank
Put
you
yourself
so
on video.
Oh boy. Okay. Hello, ladies. That was an absolutely mind-blowingly fabulous presentation, and I learned so much, and your leadership is tremendous. We want to partner with you on all of those action items and just plow right ahead. So I also want to commend your excellent visuals. So we loved the thought that you put into your presentations and the data and the heart that you brought to it. So we're your partners in advancing equity, and we have our shoulder into this work and really look forward to continuing with all of you. Thank you so much.
Sounds good.
Thank you, Heather. Thank you, Andrea.
Thanks for having us.
You're welcome. Thank you.
Bye, everybody.
Bye, everybody. Have a great day. Be safe.